Great, we're recording now.
Hello, everyone. It's a pleasure to have you with us today for what promises to be a rich and engaging session. My name is Aninjanja, a communications specialist at the Center for Epidemiological Modeling and Analysis, SEMA Africa, and I'm delighted to welcome you to this joint edition by the Global Society for Infectious Diseases Dynamics, GSIDD, and SEMA Africa. Today's webinar, under the theme Strengthening Infectious Disease Modeling in Africa, will showcase diverse modeling organizations in Africa and how they are working together to contribute to health research and response across the continent. But before we move to our main speakers, let's first hear from Lisa, who will give us an overview of GSIDD. Then I'll share a short introduction on SEMA. Then we head straight into the heart of today's session. Welcome, Lisa.
Thank you, Annie. So lovely to meet you all. As Annie said, GSIDD is the new Global Society for Infectious Disease Dynamics. And this is an initiative to promote collaborations, to drive innovations, advance the education of IDD and modeling as a field, and to advocate for our field. So we're now in the building phase where we all as a community will be solidifying the bylaws to move towards electing the leadership for GSIDD. This is a participatory process that will happen very soon. So we encourage everyone to get involved, tune in and sign up to the mailing list and the website, which I'll post in the chat. In the meantime, we wanted to connect together existing IDD organizations that are dispersed throughout the globe through this IDD Connect seminar series. And the aim is to sort of explore strengths that already exist and think about how we should build the GSIDD Society going forward. So I invite everyone to really get involved and enjoy the session. So today I'm super excited that peers from 6 organizations across Africa will be sharing with us the vibrant growth of IDD in Africa. And we have our first speaker slide ready. And we look forward to it. Annie, please launch in.
Thank you, Lisa. So a little bit about SEMA. SEMA is based at the University of Nairobi, and it's a Pan-African Center of Excellence using advanced analytics, clinical research, and epidemiological modeling to inform policy, strengthen systems, and develop the next generation of African scientific talent. Since its inception, SEMA has grown into a trusted partner to governments, multilateral agencies, and global funders, delivering rapid policy-relevant insights across human and animal health, climate, and agriculture. At SEMA Africa Seminar Series, it's a monthly learning platform where we bring together experienced and budding researchers for insightful discussions and to learn from each other. So please be on the lookout. We will be sharing more information about SEMA and on all organizations represented in this webinar on the chat. So be on the lookout for that. So our speakers for today's special webinar by IDD Connect and SEMA Africa Seminar Series are Motono Nyamai, a senior research fellow at SEMA Africa and modeling and training lead at Africa Modeling Network for NTDs, M2NTD. Dr. Mariam Diarra, a research associate at the Institute Pasteur Dakar. Rachel Hansel, health research and infectious disease modeler at Modeling and Simulation Hub Africa, Masha. Jeremy Bingham, technical lead for SOSIMA's Measles and Polio and Modeling Fellowship. Zainab Unisi, AMAX PhD Fellow, and Lulama Lunika, a Senior Program Officer at the Science for Africa Foundation, who will share how MOTA, which stands for Modeling for Health in Africa, is increasing connectedness and growing the Africa modeling ecosystem. Our speakers will give us a snapshot of their work that spans critical areas including pandemic preparedness and response, predictive modeling at the intersection of health and climate, neglected tropical diseases, and capacity strengthening. So without further delay, we will hear from Dr. Motono Nyamai, who will share an overview of modeling organizations in Africa and how they've evolved over time. And then the rest of the speakers will follow. Welcome, Motono.
Thanks, Annie, and I will dive straight into my presentation. And the best place to start from is about SEMA, which Annie has done a good job. And I just wanted to bring out that the center has a multidisciplinary approach where it brings together different people from different fields. That's either health economists, clinicians, epidemiologists, mathematicians, and data scientists, all with the aim of answering questions related to health and providing evidence. To start us off is from the COVID-19, where during the pandemic, there was a lot of research being done, and also modeling was used by African countries to inform them on the decisions to make. And some of the lessons we see from the pandemic was particularly from this paper that was published by Kimani, and it was focusing on what countries used modeling to guide policy, and it was evident that modeling use was not uniform across the continent, and particularly 2/3 of the manuscripts that were published as at this time were from just 3 countries. So from here, there has been pathways to strengthen modeling capacity in the continent, and 2 main publications bring this out, and one is a piece by Thumbi, Jackie and Chital that talks about 4 ingredients required to strengthen policy modeling use in Africa. And the ingredients are 1, on local capacity for model generation, capacity of policymakers to ensure that they use the results for decision making, and also effectiveness of communication between the 2. That's both the policy makers and also the people who generate the models. And ultimately, establishment of centers of excellence on policy modeling in the region. But to get there, there's a route to it. So the 3 interventions that are required for countries to move from the point where they have training in academic modeling all the way to establishment of the centers of excellence, you need foundational interventions where there's training in academic modeling and also policy modeling. And once you move from there, then you get to the supportive phase, where now you ensure that you have data that is able to support modeling and also establish collaborative networks within the continent, so as you use each other's strengths to answer the questions. And ultimately is a connective interventions phase, where then you train the people who do modeling to effectively communicate to the policymakers, but also you create centers of excellence, and here you also have a framework in how you communicate to the policymakers. A lot has been done in the continent, and I just went back and tried to look at some of the institutions and consortiums within the continent that they are funded to do work on modeling. And all of these institutions that are captured, they focus, 1, at the core of it is on capacity strengthening, and also secondly, they give a career development pathway where you retain the modelers who are trained in the continent to answer local questions. And thirdly is the establishment centers of excellence and leadership. And you can see this with the different organizations that have been captured on the screen. And then finally is on structured policy engagement, where you have policy champions. And a good example is the World Health Organization Africa Region Office that are able to, yes, take up the results, work together with the modelers to have these outputs, but also communicate now this in terms of policy. Now coming to SEMA, we focus on 3 main things when it comes to answering the questions from policymakers. So we start from the epidemiological modeling, epidemiological models, where we need to know where is the disease and what's the prevalence and incidence all the way to granular level. And then we add more advanced geostatistical techniques, where we add the environmental and socioeconomic variables to have georeferenced and gridded surfaces to show us where the prevalence is at a lower level. And then from there, we do the transmission modeling to look at what are the different scenarios to have precision public health and add a cost to it, so that policymakers know that it's just not on these interventions, but this is how much it will cost them. To start us off on the understanding health and health systems, a good starting point would be on the data warehouse. And we realized that there was a lot of fragmented data during COVID, and many people are keeping the data either in their computers or in their department, so there was a siloed approach to data. So we've tried to put all the data in a central repository that can act as a one-stop shop, where if someone wants to do any research on the human and also animal health, then this repository is a good starting point on the data that's accessible, or ways in how you can get the data. Then once you have the data, a good example is now to look at are the services that are being offered available to the population, and if they're available, are they ready to offer the service? And readiness here, we look at equipment. Do they have the right equipment, the right personnel, and the right infrastructure? And an example is on the primary health care, where you can see on the maps where we have that every dot represents a facility that says it offers primary health care service. Then the next thing we did is to look at, are these services accessible to the population within 120 minutes, and also either from 30 minutes all the way to 120 minutes, and then looking at it when it comes to now ready facilities. And we see that in terms of availability, the number is high, more than 80%, more than 90%, but it comes down to around 80% when you look at the readiness. So it's just not only on where are the facilities, but are the population able to access them. But we just don't do this in the human health, but we also do this in the animal health. And we have some work where we try to look at the services that are offered in the human health, that's either on the veterinary and agrovet services, how accessible are they to the farmers who need them. The next bit is on optimizing delivery of interventions. So once we have the data, we know where the prevalence is and the cases at a granular level. Then the next bit, we do scenario modeling to just look at, is it a one-size-fits-all, or we should move to more of targeted interventions. And an example is on measles, where we did mathematical modeling to just see at a subnational level. And the aim was to look at what has been the impact of vaccination from 2010 to 2024, and to move all the way to 2030, especially when they focus on the catch-up vaccines. Should they do a one-size-fits-all, or they should target? And we saw that for areas that have done a lot of vaccination in the younger years, then the catch-up vaccines need to also target the older ages, compared to the ones that have had a lower coverage for the children below 5 years. But it's not only on the catch-up vaccines, but it's also on the timing of the interventions. And some work to show this is on cholera, where we did some mathematical modeling to just evaluate the effectiveness of the oral cholera vaccine during an outbreak in Kenya. And as they had distributed it 120 days after the first case, then the effectiveness of this was at 38%. And we looked at a scenario, what if it was given at 30 days after the first case? And we saw that while they gave it at 30 days, the effectiveness moved all the way to 76%. So bringing out the message that, yes, we need to target the interventions, but also the timing matters. And the last example I'll give on this work on optimizing delivery of interventions is on schistosomiasis, where there's a need to now move from blanket treatment, where we use a one-size-fits-all, but more of targeted interventions. So as countries reach the elimination threshold, that's targeted for 2030. And we see that when we increase the frequency of treatment in the high prevalence areas, then we accelerate the elimination efforts. And also, if we switch from campaign to routine treatment, which is already being used by other diseases, then we even get there faster. So once we've used the data, then we've done the scenarios, then the third thing is, how should the money be effectively used? And this is where now I talk about more money for health and more health for money. And an example here is on malaria, where after the mathematical modeling was done to just see the effectiveness of switching from one net with one treatment compared to having a dual treated net, then we saw that it was cost effective to switch to the dual nets compared to just using the single net. And this now helps the policymakers have the right ingredients to make a decision based on all the different strategies you've given them. And then we move now to the last question. Are the health treatments or interventions effective, safe, and worth the cost? how you answer this is through health technology assessment. And a lot of countries now in the continent are starting to take up this health technology assessment. And I'll give an example of cancer treatment in Kenya, where in 2025, we went through health system reforms and we moved to a social health insurance fund, where now everyone was contributing to it based on your resource muscle. And the idea was to ensure that the people, everyone is able to be covered by the insurance. And when it started, the cancer costs were put at $3,900. And using now evidence, that's from the data that I've shown in the first bit that's required, and also results from the epidemiological modeling and also the health economics modeling, we were able to see that actually the cancer costs should be covered at around $6,200. And from this health technology assessment, this evidence was able to be given to the policymakers, to be presented to the policymakers, and they've actually taken this up, now moving it from $3,900 to $6,200. And so this just gives you an idea of how we are able to improve decision-making in the continent when we use all our different multidisciplinary approaches to all work towards improving health, but also ensuring that it's effectively used and in a sustainable and cost-effective approach. And as I finish off, I'd like to leave you with this word where, yes, sustainable health gains in Africa will be built by local modelers who will be working as part of multidisciplinary teams and collaborating closely with decision makers, because they are the ones at the end who need to make the decisions, and they need to be connected across the continent, bringing together now the networks within and the consortiums within the continent. And importantly, this will be strengthened through equal partnerships with our global peers. So as much as we work towards improving the continent, we need to also be at a point where we have equal partnerships with the teams in the high-income countries. Thank you.
Thank you so much, Mutono, for being able to share so much in such a short time. So we will move to the next presenter, Dr. Mariam Diarra, in the interest of time. Please go ahead.
Okay, thank you, Annie. Hello, everyone. I'm happy to be here today to talk to you about some modeling initiative at Institut Pasteur of Dakar, Senegal. So Institut Pasteur belongs to the Pasteur Network with more than 30 institutes belonging to 25 countries. And the main activities in IPD are research, education, training, medical expertise, production of yellow fever vaccine, rapid diagnostic tests, etc. In our department, the epidemiology and data science units, the modeling initiatives are mainly to support decision makers. We are doing model forecasting, especially developing tools for early warning systems, to anticipate for future outbreaks. We are also doing impact assessment, like evaluating the impact of climate change. We are also evaluating the non-pharmaceutical interventions, but also different vaccination strategies. We are also doing economic cost assessment, especially cost effectiveness analysis. Coming to the climate and health modeling study, first of all, I want to present you the forest network. By forest, I mean syndromic sentinel surveillance network, and this network has established since 2015 in 2015 by IPT in collaboration with the Senegalese Ministry of Health. In this map, this is the distribution of the 43 sentinel sites in the country, and the syndrome and the surveillance are influenza, herpesviruses, hemorrhagic fevers, malaria, febrile diarrhea. And the objective of the forest network is to detect outbreak and stop them at the early stage. Here you have just an example of detected outbreak during 2022, and you can see that most of them are dengue outbreaks. That's why we will focus here in the climate and health study, we will focus on dengue. And the objective is to strengthen this forest network with early warning system, integrating climate data to build these early warning systems. And this tool will be implemented here in the north at Anyam Civil Health District, and in the south at Moustukula Health District in the western part. And we will use the EWOS model. By EWOS, I mean early warning and response system for climate-sensitive disease. This tool was developed by WHO TDR in collaboration with Columbus and Freiburg universities, and this tool was designed to effectively predict epidemics for climate-sensitive disease around 8 to 12 weeks in advance. This tool has been implemented in 17 countries, and Senegal started the pilot study in 2025. And to use this tool, you need at least 3 years of retrospective climate and health data, but also population data and entomological data if you have. The tool will learn about your data sets to identify the climate condition that may explain past outbreaks, and then capture this information. And once well calibrated, the tool will be used to make predictions based on real-time climate data for each site. And then here, this is just an example of the model forecasting. Here, for example, in Bourtocolor Health District, in green line, you have the alarm threshold defined by the model. In red line, you have the predicted incidence, and in blue dots, you have the epidemic probabilities. Once these exceeds the threshold, it's translated into alarms. And as interpretations, you can see that based on the average meteorology recorded during week 44 of 2025, climatic conditions are conducive to dengue transmission for weeks 45 to 41, with an increasing dengue incidence predicted. And here we have, based on the WHO algorithm, we can classify with the traffic lights the level of incidence or the level of outbreak, red from green to red. We can have also this same interpretation, for example, for Anyam Civil Health District, but here the traffic light is in green months. And how to communicate these results with the Ministry of Health. We are producing weekly bulletins to inform our predictions. And we are sharing with the Ministry of Health and those responsible for the response in the health district. And today we shared 32 bulletins with them. And this is how the bulletin looks like. And I highlight in the red part the dengue outbreaks risk prediction and the interpretation. And the green part, I highlight the recommended response guided by the level of alarms and the risk mapping. And then this part was built in collaboration with all stakeholders to take into account the particularity of Senegal. And here has an example of response to alerts. You have here awareness campaign organized, for example, in Anyam Civil. They have did many responses to avoid future outbreaks. But also here you have entomological teams going to the field, doing investigations, try to identify larvae to determine the entomological parameters that can guide control strategies and formulate effective or the most efficient recommendation for the type of response. And then I want to thank all partners for this study, mainly all stakeholders, especially WHO TDR, WHO Senegal, all department from the Ministry of Health involved, and also all department involved in IPD. So thank you.
Thank you so much, Mariam. So we move to Rachel. Rachel, please go ahead. You're muted. Hi, Rachel. You're muted.
Great. I hope everybody can hear me now. So I'm Dr. Rachel Hansel, and I'm presenting on behalf of the Modeling and Simulation Hub Africa. And my aim today is just to give you an overview of who we are and what we do, and we'd love to connect with other modelers from across the continent. So Masha is a Masha is a research group that was established in 2017 based within the University of Cape Town. And our primary area of research is looking at policy relevant modeling of specifically vector-borne, epidemic, and vaccine-preventable diseases. So really interdisciplinary by nature, combining maths, computer science, biology, medicine, economics, finance, and public health. And Matono did a wonderful overview of how those different fields can come together to have impact within the health space. So our health scope is quite broad. We work across a wide range of diseases, as well as more broadly across epidemic preparedness and response and health system modeling. So although we're based in South Africa and do a lot of work in our own country, we also have partnerships and work in countries across Africa and other LMIC. In terms of training capacity building, that's something we're also really passionate about and spend a lot of time working towards. One of the projects is something called Malaria Modeling and Analytics Leaders in Africa, or MALA. And that's really about advanced training for emerging researchers, building leadership in modeling, analytics, and the translation to policy, and strengthening African expertise and networks. So the two main branches of this is our MALA PhD program, which has 2 masters, 11 PhDs, and 3 postdocs. And then also something called the Regional Malaria Modeling Translational Fellowship, which we launched the first cohort last year. And what that is, it's bringing together fellows. So we had 21 fellows from 7 different countries, all working within their malaria control programs and ministries of health. And the intention was not just to build the capacity of modelers, but also to build capacity and skills within people who use modeled evidence. So that was a 6-month executive fellowship hosted by the University of Cape Town, funded by Gates, and with partnerships with CHAI. And it was a really exciting opportunity to look at the translation of modeled evidence into policy. And then more broadly, also do several different courses and workshops around training disease modelers and partnering with different ministries of health to develop skills in the uptake of modeled evidence. So I'm just wanting to touch on a couple of our projects to show you what we're working on, and in particular, if there are any of these overlap with the work that you're doing, we'd love to engage with you. And several of these projects, we have partners who are presenting today or on the call. So CAMISA, it's a climate-focused analytics and modeling for mosquito-borne infections in Southern Africa. And what this does is combine climate science, entomology, and mathematical modeling to understand and predict the spread of vector-borne diseases under shifting climate conditions in Southern Africa. So it's a consortium with a lot of partners across the continent, funded through Wellcome. And then our second one I'm wanting to touch on today is a project called Health Radar, which is responsible access to data for analysis and research. And it's a central resource for disease modeling, specifically around climate-sensitive infectious diseases. So there are data sets, guidance, and tools for GSIDD modeling, and that's already publicly available. I've put the QR code here, and there's also a link that will be going in the chat if you'd like to explore. The data sets are available, but we also encourage contributions to Health Radar around developing data sets, editing content, and providing feedback. Then we've also done some work with measles and rubella, and this is a more public-facing piece of work. It's around a dashboard that provides live insights for measles and rubella risk in South Africa. And it's to increase the awareness of vaccination benefits, increase vaccine uptake, with a public-facing working in partnership with the South African Department of Health, our genomics, wastewater genomics unit at NICD, and the South African Medical Research Council. And the last project I'd like to go into a little bit more detail, it's still quite new, and it just started towards the end of last year, is Clear Africa. And Mariam, who just presented, as well as Seema, are both partners on this project. So it's a really exciting collaboration with 6 different modeling units across the continent. So Clear Africa stands for the Consortium for Leadership of Epidemiological Economic Analysis for Epidemic Response in Africa. It's really around epidemic preparedness and response, but integrating both the health and the economic impacts. So our consortium has 6 partners from 5 different countries and is funded by the African Pandemic Sciences Collaborative. So this we launched in October last year. And the aim really is around protecting lives and livelihoods during health crises. So during COVID, there were quite a lot of lessons that have come out. But one of them was that a lot of modeling and a lot of the policy response focused on protecting the health impact and sometimes neglected or at the cost of the economic and livelihoods. So in terms of building tools to predict, prepare for, and mitigating the next pandemic, we're looking at integrating epidemiological and economic models, not just your standard micro cost effectiveness, but also on a macro scale, where you can start looking at things like the impact on GDP, on job losses across different sectors, and understanding what different interventions, what effect it might have more holistically in the country. So here we're connecting Southern, East, and West Africa. So we've got consortium partners in Cameroon, Kenya, Senegal, South Africa, and Zimbabwe. And this is a big 5-year project focusing on kind of the technical modeling, developing tools, building leadership, working on the policy translation, and also providing training. In the epidemic preparedness and response space, we're also, so Masha was very involved in the South African COVID-19 modeling consortium, where we learned a lot of lessons around doing modeling within an epidemic or pandemic setting, and also have been doing work in diphtheria. So with diphtheria, we worked with the Nigerian government during their outbreak in 2023 and help them develop transmission risk maps to look at how do you optimize the delivery of vaccines when there's a limited stock and there's a very short amount of time to make decisions to have maximum impact. So that was some of the work that we did in the midst of the epidemic, but also in developing decision strategy tools, looking at diphtheria, tetanus, and pertussis boosters to support country level decision making on the introduction of those boosters to protect again, so reduce cases in terms of pertussis and tetanus, but with diphtheria, looking at how do you develop or increase your population immunity and lower the risk of outbreaks as more and more of these are happening around the world at the moment. So that's hopefully given you a flavor of who we are and what we do at Masha in terms of opportunities to connect. I think first of all, let's talk, especially if there've been any kind of diseases that I've mentioned that you're also working on. We'd love to connect on those. We're always interested in collaboration and having calls to learn from each other. And explore and contribute to the Health Radar and join one of our training sessions. And we also host various research visits and opportunities for collaboration. Thank you very much. I'll hand back over to Annie.
Thank you. Thank you so much, Rachel. And awesome. Thank you. Thank you so much, Rachel. And we've posted some information on some of the work she's doing and the Health Radar tool. So please ask for some of the details. Jeremy, the floor is yours. Go ahead, please.
Thanks, Annie. Sorry, the connection was a little slow there. It might be my end, so we'll just wait for your cue. Hi, everyone. My name is Jeremy Bingham, and I'll be speaking today about a capacity development and service delivery initiative, the SACIMA Policy Modeling Fellowship. And to start off with, I'd like to say a big thank you to the relatively small team of people without whom this success of the fellowship would not be possible, and all of whom work extremely hard throughout the year. So the fellowship is based at SACIMA, the South African Center for Epidemiological Modeling and Analysis. We have a relatively small staff contingent and a growing number of postgraduate students. We also play a leading role in the ICI 3D clinics, the flagship clinic of which is the Meaningful Modeling of Epidemiological Data, or MMED clinic, that takes place for 2 weeks in the middle of every year in June, near Cape Town, South Africa. It's a fantastic clinic, and I highly encourage everyone to get involved in ICI 3D clinics if you have a chance. And although this is an incredible course, and it does form part of the fellowship, 2 weeks is still quite a short period. And in reality, to become the person that a government stakeholder or an international organization's decision maker turns to for information support, for allocating large amounts of resources, it takes more than 2 weeks. And one needs to have a whole bunch of things put together, including real world experience. Postgraduate degree programs, they have the duration that's required, but they also come with their own built-in incentives and constraints, which often limit the real-time policy support role that postgraduate students can play or do play. And this, as a result, also limits their experience in these roles and the necessary relationships with stakeholders that they have as they graduate. So this brings us to the Policy Modeling Fellowship. And thanks also to Mutono for laying the groundwork for why this is important. So the goals of the Policy Modeling Fellowship are twofold in summary. The first is to build long-term capacity in people who work within or in closely allied institutions to African ministries of health. And the second goal is to provide a genuinely useful service at whatever level to stakeholders and decision makers in ministries of health or in vaccination programs in African governments. So to achieve this, there's two broad forks of the fellowship, two facets to the effort. SACIMA has the expertise in modeling and experience engaging with stakeholders. So we provide mentoring and technical training to fellows. This is really intensive throughout the year. It includes weekly one-on-one meetings with the fellowship managers, Dr. Sade Horn and Dr. Marshall Ngunu. It also includes 2 extremely intense visits to SACIMA, where fellows are working 8 to 12-hour days, 5 to 6 days a week. One in the middle of the year to work on technical methods and to apply their country's data to the methods, and one later in the year to practice for presenting to stakeholders. Then the second component of the work is engagement with stakeholders, and this is driven by fellows. This is the fellows' responsibility, and this is so that fellows build these networks and relationships that can have like an ongoing service delivery through them. So that brings me to the principles of the fellowship. The first of which is impact through service, and the emphasis here is really on service. The fellowship team sees ourselves as being of service to the fellows. That's why we're doing what we're doing. And we also really encourage the fellows to place themselves and their posture towards stakeholders as one of service, to find out where can they be useful and how can they be of service to stakeholders. We believe this is the most effective way to have impact. The second principle is to be flexible and adapt. The reality is, across the world, and certainly in Africa, things don't always go exactly according to plan. And if you have a plan that's really set in stone, even small wobbles will set you completely askew. So we really take things as we go. We have a plan, but we adapt as we go with feedback from the fellows and from other sources. Next up, on the methods front, we are not aiming to have a detailed methods development program. We identify simple and robust methods that can be adapted to utilize locally owned data. We look for methods that can help countries decide how to target interventions and resources very broadly. And then finally, and the last principle is respect with accountability. And this is one that personally takes a lot of effort throughout the year. And this is because in order to build a true fellowship, we need to maintain a sense of collegiate respect that we share with the fellows, because I'm not super old or super experienced. And even if I was, I would want to have a collegiate relationship with the fellows, all of whom have experience and perspectives that I don't have and that I want to learn from myself. But at the same time, the fellowship is a really, really challenging program and requires the fellows to be pushed in order realistically to get through it. So there's that aspect of accountability, and holding these two together, it takes some effort and attention. Very briefly, the fellowship starts with recruitment. This year we had over 500 applications. The fellows go through preparatory training and courses. They also engage with stakeholders in the country to sort of set up the relationship and expectations for later in the year, and to find out what do the stakeholders want. I want to highlight here that I've been really fascinated to see that across the board, stakeholders in each country have been very interested in what we might see as quite fundamental or basic questions along the lines of like, when was the last biggest outbreak, or questions that seem relatively straightforward. The fellows then come for 2 in-person visits, and then they travel home at the end of the year to present results to stakeholders. And the SACIMA team aims to visit each country with the fellows. These are the 2026 Policy Modeling Fellows. See, Brian is in the audience. We have 3 fellows focused on polio and 5 fellows focused on measles. And these are their locations. Finally, if you'd like to get involved, there's 4 broad ways. Firstly, if you'd like to mentor a current or past fellow, either someone who's in the fellowship or in the fellowship alumni program, please reach out. Even if you're not sure what exactly the mentorship role that you would be suited to provide is, please do reach out to me. If you've run some kind of capacity development initiative and you have lessons that you'd like to share, or you'd like to hear lessons that we've learned, please reach out to me. If you'd like to become a fellow, please apply. Applications will open in September to November this year. And then finally, we're looking to grow the team, the fellowship coordination team at SACIMA. So if you're interested in joining the team in a full-time or part-time capacity, please reach out to me. Here's to a stronger Africa together.
Thank you so much, Jeremy, for that presentation and making case for why capacity strengthening is really key to eradicating some of these diseases. So we move to our next presenter, Zaina. Please go on.
And today I will present AMAX, African Modeling and Analytics Academy for Women. So before that, I wanted to present my modeling team at BIMS Lab, Bioinformatics, Biomathematics, Biostatics Lab at Pasteur Institute of Tunis, with about 15 members, professors, postdocs, PhDs, and doctors. We do like two things. We do vaccination strategies and we do ecology, epidemiology interactions in interaction with different organizations in the country. And with these countries, we work with the Minister of Health in order to provide evidence to help them making decisions. And also, we are the intersection of multiple networks. We are a focal point of Pasteur Network. We are leading AMAX, as I will present today. We are founders and members of Global Health Network MENA region. We have a member of Vaccine Impact Modeling Consortium since 2023. So AMAX is a project, as I said, it's founded by Bill and Melinda Gates Foundation in the aim of create an ideal environment to train PhD students and postdocs in Africa, led by Africans, focused on African health issues with a gender awareness approach. This project is led by Pasteur Institute of Tunis. So by its PI Emira Kabir and co-PI Slimane Ben Millet. It's also led by Pasteur Institute of Senegal, Mbara University of Science Uganda, Center Pasteur Cameroon, CELMES Niger, and SEMA, in the purpose of focus on women's health issues, enhance the number of modelers, especially women, strengthen capacity building efforts, and promote data-centered collaborations. So, within AMAX, we have 11 PhD and postdocs. 1 PhD and 5 masters are already defended. We also do weekly scientific webinars since 2024, which are led by AMAX students. We do also yearly training schools. The first one was in Tunisia, the second was in Cameroon, and now we're attending the third one in Nairobi. Within this school, we had like more than 100 trained modelers. 55% of these modelers are women. So, in addition to the capacity building aim, AMAX aim also to provide evidence to help public health decision making. So via different diseases and in the different country levels. So now I wanted to share with you my experience as a PhD and a Max Fellow. So my background was on pure mathematics. I did pure mathematics at my license, and also at my master's I do applied mathematics, but it was not really applied. And in my PhD I was selected as a Max Fellow. So this gave me the capacity to learn how to frame modeling around well-defined public health questions and how to bridge the math, the theory that I have, the capacity that I have to real-world health outcome. It made me also have the first hands on epidemiological data sets and like learn fitting, calibration and validation techniques. It made me also able to calibrate with different disciplines, epidemiology, virology and public health. An example of my research work are the HPV vaccination strategy that we worked on in Tunisia because it was a problem of implementation of the vaccine in Tunisia, and also in collaboration with Burnet Institute in Australia, we worked on calibrating measles outbreak within Gavi eligible countries in order to testing preventive, reactive or mixed strategies. So I wanted to say that I'm really happy to be part of AMAX. I'm really happy that AMAX will continue for the next 3 years. So it will make their students use their learned capacities to more be communicated with public health decision makers. So thank you very much.
Great. Thank you so much, Zainab. And I've had the pleasure of working with a few AMAX fellows, including Uma and Joy Kaleche and Ekanat, to bring in different institutions to like train the fellows. It's such a great collaboration to ensure that we still continue to nurture the next generation of scientists. So we will move to Lulama, who will, share with us how Malta is trying to bring all these institutions and organizations and the work being done in Africa together. So Lulama, take away.
Thank you so much, Annie, and good afternoon, everyone. As Annie mentioned, my name is Lulama Lunika, and I am from the Science for Africa Foundation, which serves as the secretariat or the implementer of MODA. And MODA really is an African-led initiative that is focused on strengthening modeling for health and bringing modeling closer to decision-making and policy across the African continent. And so this is a very quick kind of process or step in terms of how we came about as a network. But I've kind of highlighted a couple of very key steps for us in kind of our emergence. The first is that we really emerged from conversations that were held at a Kigali modeling workshop in 2023, where various funders convened and brought together different modelers across Africa Africa researchers and funders, as well as partners, to reflect on what are the persistent gaps really between modeling and policy making in Africa. And from that discussion and from that workshop, really it led to kind of a funding call under the Grand Challenges Africa umbrella, where Gates and Wellcome Trust are partnered together to release a funding call, an RFP, and 12 projects were selected and were successful from that funding call. Eight were funded by Gates and 4 by Wellcome. And those projects then were kind of handed over to us as a cohort as the Science for Africa Foundation. We became the secretariat. And the idea there was to convene them, establish connections between the different projects, peer-to-peer learning, collaboration, and so forth, and to support them throughout their journey of implementing and working on their projects. And then officially in November of 2025, we held an inception meeting where we brought together all of these projects, and we started really the journey of MODA together at that meeting and up until now. And so what are we trying to achieve really with MODA? I think the first thing is really we want to provide a platform where we can amplify African-led approaches in modeling, as well as strengthen local leadership in modeling. And so part of the RFP process is to really, strengthen local leadership and to amplify what is already happening within the African continent. The second is to increase connectedness and to grow the African modeling ecosystem. We know that the modeling ecosystem at the moment is relatively fragmented, and so we want to bring people together and we want modelers to know about each other's work through this platform. And lastly, the bread and butter of MODA is really to bring modeling closer to decision making, as well as to policy impact. And so we want to highlight and document as much as possible all the stories of success regarding taking modeling and bringing it to decision making and policy. And so this is the likelihood of MODA's journey. At the moment, we are still very much a cohort of researchers that was successful through the funding call. There are initial connections and trust at the stage, as well as learning and dialogue that's taking place. But we really want to get to a place where we evolve into a network and eventually a community of practice where there is really a lot of joint initiatives, partnerships, where there's collaboration, and we want to have a very vibrant and robust platform where everybody is engaged and working with each other, such that even if SFA Foundation steps back, these connections would still, continue and still kind of work together even outside of our role. So this is the likelihood progression and evolution of MODA in the coming years. And so who is a part of MODA right now? And so we have 12 projects that are led by 12 PIs. 3 of the initiatives that were presented today are already part of MODA, which is really exciting. But just you can see, we are spread across Southern Africa, East Africa, and we have one project that is also in West Africa. And the topics or the areas of modeling that take place are around malaria, cervical cancer, climate-sensitive diseases, serious surveillance, workforce planning, as well as endemic disease modeling. But what's really important is that these projects do not work in isolation, but there's a lot of already cross-country collaboration within Africa, and also within each other's projects already. And also we have partners, or there are collaborators that are also outside of the African continent, but many of them are within the continent and already working with each other, which is very exciting. Lastly, this slide is just to show that we are starting to kind of organize ourselves as a network. We are thinking around, who should be on our advisory board. One key principle for us is that we are Africa-led, and so we want representative at the advisory board level that is also African-led and African-based. Our steering committee will be comprised mainly of the model projects themselves, and this is where decision making will be made for the network. Ourselves as a secretariat, as SFA Foundation, we have a whole team that supports me in managing and implementing the activities of the cohort. One thing I really want to point out is the thematic working groups. And so these are platforms for model members to self-select and decide kind of what sort of key themes they want to participate in and also focus on in their journey. And this is an opportunity for more of that cross-collaboration and working across different projects as well. And these will be entirely led by model members. And so just to say that our aim is not to just have governance, but we really want to create a collaborative structure that enables both leadership as well as ownership within the network itself. And so lastly, we really want to work with other initiatives. Again, we are trying to link up with other initiatives and all the great work that is happening on the continent. And so you are very much welcome within MODA. We want to work with you. And so please do reach out. We would be very happy to continue the conversation and explore any opportunities for collaboration. Thank you very much.
Great. Thank you, Lulama, for that highlight. Great presentation and a case for how and why institutions and researchers shouldn't work in silos and how you're bringing them together. And I think that's a great thing. So we enter the Q&A session. So if you have questions, please raise your hand or post in the chat and pose the question to our speakers. And we already have one from Richarda Pangam. One issue is data sharing across the region. How are the modeling networks working around this when doing this modeling across the countries? So I think this is an open question. Motono, Rachel, one of the speakers can take it up, please.
I'm happy to give a 2-second reply.
Awesome.
Which is just to say, our approach is to recognize that like certain health data, like line lists, is always going to, and even births, is always going to be politically sensitive. And so as part of the fellowship, we don't require access to the fellows' data. That's the fellow's job, is to build the relationship with their stakeholders and acquire access to the data so that the data stays in country. So basically to have a kind of maintaining data sovereignty as an approach, rather than trying to bypass the need for data sharing, because I don't want to go on too long, but I think that international sharing of data, although it is very, very useful and we all benefit from it, it also does come with its own limitations and can lead to some issues.
Okay.
So I can add on
Rachel.
briefly if we're waiting for another. I also wait for another question. So the health radars, I completely agree with Jeremy's approach. I think country-owned and country-level data that is politically sensitive, and you need data sharing agreements. There is a system in place. It can be time-consuming, but developing relationships with the countries and with your policymaking partners, I think, is vitally important. For publicly accessible databases, I think both the radar platform that we're developing, as well as the CMO's data repository, are initiatives that are helping to try and make or raise awareness of what data is available, what are some of the challenges or information around the data set, so you can get oriented around what data exists, how they can be used, things to think about, or in where that they're sensitive, who you might be able to contact or just like what is out there and how do you access it. So there are some continent specific data repositories, both Health Radar and the one that SEMA is running, but I think is also some great initiatives to make some of the data more available and in a way that modelers can use it. Thanks.
Mutano, would you like to give the SEMA perspective or any other speaker? We can't hear you.
Down to
Awesome.
having relationships with the owners of the data and closely working with them to ensure that you answer the question that they would like to and provide evidence for them to make decisions, and also working with someone in the country. So having a local modeler, and I think that's the strength of the consortium, where the same question can be answered in multiple countries with different modelers who are stationed in the different countries.
Thank you. And I also want to add that we have this Q&A session, and we plan to extend it later on once we end the main session. So in case anybody would love to have an interaction with the speaker or the speakers, they're welcome to stay later on. But to carry on to the second question by Hart, would love to hear from several fellowship programs what adaptations often are needed to navigate the complex external factors around the fellowship work. So that looks like a Jeremy question, or any other person can.
I'm happy to say, I think in the question is the fact that the factors are often complex, and the biggest factor that's required is persistence. There's no one size fits all approach, and not giving up, not respectfully not taking no for an answer, and showing up, showing what you can provide, and just communicating as well. I think trying to set up. It's very easy, especially when you're collaborating internationally, and when there's like a fellowship program, for example, which I think this is what I was trying to get at a bit with the respect and accountability. There's something natural in a fellowship program where things can fall into like a student and teacher or like a hierarchical kind of approach, but that also doesn't lend itself to, when it's coupled with a lot of accountability, it doesn't always lend itself to clear communication about issues, because people don't always feel safe to say what's really going on. So I think along with persistence is like setting up a safe space to communicate clearly, and then, yeah, being willing to adapt.
Thank you, Jeremy. Roya is asking, is saying, thank you for the presentations, very inspiring to see all the fantastic work being done across Africa to strengthen the use of models for decision making. I have two questions. Zainab, you mentioned that AMACs have been holding weekly scientific webinars. Is this open to everyone? If so, please could you share the link? And I think some of this information we can share later. And we've also used this chat to post about AMACs and some of the resources around the program. So if you could revisit that, and then we move to the next question to Jeremy. How can people get involved in the IC13D clinics?
I think the best way to do that is to follow SACIMA on LinkedIn and Twitter, and I think ICI3D also has a LinkedIn, and look for the applications when they go out. So the DADE clinic happens towards the end of the year, so applications will come out probably in 2 months' time. Kari in the audience may chime into the chat with more clarity as the director of ICI3D. And then MMED clinic applications closed, I'd say 2 months ago, the end of March. So look out for that in the future. And in terms of the first place to get involved is to attend one of the clinics, but also you could reach out to Kari directly if you are perhaps in a more senior position and want to get involved in some other way.
Yes, and there's just so much to share, but we are time constrained, And please just use the resources we shared on chat to visit these organizations and see the amazing work they're doing. So thank you so much, all of you, for joining us today. So I want to thank especially the speakers, and on behalf of GSIDD and SEMA, a sincere thank you to everybody who brought their expertise, inspiring work they're doing across the continent. Thank you also to the organizing team and the GSIDD for the wonderful partnership. Special thank especially to Purity of SEMA, Lisa, Hart, and Shweta from GSIDD for making this webinar reality. And Shweta could not join us today due to a family emergency, and she requested we pass her apologies. For those who have further questions, you can still hang around and ask. We will be around for a few more minutes after the main session ends, just in case you have something pressing to ask. To everyone, thank you so much. We hope this session sparked new connections and ideas, and we look forward to welcoming you to our future sessions of the SEMA Africa Seminar Series, and of course our partner IDD Connect. But before we move on to the open session, I once again invite Lisa to give us closing remarks from GSIDD.
Thank you, Annie, and thank you all the speakers. That was fantastic. So we'll share a recording via the GIST website, and it will also be on the SEMA YouTube page. So just to say that we'll be continuing our sort of exploration around the globe soon in the next session of our GSIDD IDD Connect series, which will spotlight on Asia next month, early or mid-June, I think. The date will come out shortly. So stay tuned to the mailing list, and we look forward to seeing you there. Annie, so yes, I'll pass back for more kind of open discussion for anyone who wishes to stay on and ask further questions. Thank you.
Thank you. That brings us to the end of the main session. Our speakers will stick around for a few minutes in case somebody has a pressing question they want to ask. Thank you all for attending. Jeremy, someone is asking if they